Good evening, everyone. I would like to thank you all for taking out your precious time from your busy schedule. This webinar is organized by Banai, Behavioural and Neurosciences Academy of India. Banai is a not for profit organization formed in 2012 and has organized more than 200 plus programs nationally and internationally. Focus of Banai is to provide contemporary cutting edge on behavioral neuroscience. Banai is formed and runs under the guidance and chairmanship of Dr. E. Mohandas. Banai welcomes everyone and anyone who is interested to join. It gives me immense pleasure to introduce Dr. Shaul Amin as the moderator for today's webinar. Thanks, Dr. Shaul Amin, for accepting to be the moderator for the webinar. Dr. Shaul Amin is a consultant psychiatrist, St. Thomas Hospital, Changanacheri, Kerala. Dr. Shaul Amin is the editor, Indian Journal of Psychological Medicine. Dr. Shaul Amin has passed his MBBS from Government Medical College, Calicut, and has done his MD in Psychiatry from Central Institute of Psychiatry, Ranchi. His area of special interest are de-addiction, mood disorders, and schizophrenia. In 2013, Dr. Shaul Amin was elected for the Early Career Psychiatrist program conducted in Colombo by Asian Federation of Psychiatric Societies. In June 2015, Dr. Amin was elected for Young Health Professionals track in relation to the International Congress of World Psychiatric Association held in Bucharest, Romania. I would now request Dr. Shaul Amin to take over and start the session proceedings. Over to you, Dr. Shaul Amin.
A very good evening, everyone, and a warm welcome to today's program. Let me start by thanking the Banai team and the organizers for giving me this opportunity to be a moderator of this wonderful session. I am sure that all of us are in for two highly informative sessions and a very fruitful evening. Let me introduce our respected chairpersons, Dr. D.K. Deshmukh and Dr. R. Satyanathan. Dr. D.K. Deshmukh holds an experience of 55 years in the medical field. He completed MD and DPM from KEM Hospital and Seth GS Medical College, Mumbai. He has been a professor and HOD psychiatry in JJ Group of Hospitals and Grand Medical College, Mumbai. He has a teaching experience of 35 years. And currently, he is the senior consultant psychiatrist at Lilavati Hospital, Mumbai. And he has been the president of IPS West Zone. Now coming to the second chairperson, Dr. R. Satyanathan. He obtained his MD in Psychiatry from Madras University and his Masters in Public Health, MPH, from the University of North Carolina, Chapel Hill, USA. He has served as the Director of Mental Health in the Government of Tamil Nadu, and currently he is the HOD and Senior Consultant Psychiatrist and Head of Geriatric Care Clinic at Sri Ramachandra Medical University, Poru, Chennai. Before handing over to the chairperson, I would like to remind all the viewers that we have a very huge prize in the end for the best question. So pay the closest attention possible to the speakers and keep thinking about the various aspects of the topics they are presenting, so that and you enter your questions in the chat box, and in the end the chairpersons will be deciding the best questions, and the person who asked the question will be receiving a 5,000 rupees worth e-voucher from Amazon. So with these words, I hand over to Dr. D.K. Deshmukh to introduce the topic. Please, sir.
Hello. Can you hear me? Hello, good evening, everybody. This is Dr. D.K. Deshmukh. Well, I thank you. Well, I thank the organizers for having invited me to chair this webinar. Complex psychopharmacology in medically ill patients is a very exciting subject, a very challenging subject, and it has been very close to my heart, having spent my lifetime in general hospital psychiatry. This is a field where a very close cooperation and coordination between the physician and the psychiatrist is of utmost importance for the good, effective, and safe patient care. There are lots of issues involved. We have medical side effects of psychiatric medication. We have psychiatric side effects of non-psychiatric medications. We have the conundrum of drug interactions. And the challenges continue to increase as we have got more and more drugs pouring in and more knowledge about a variety of disorders. and their effects on body and mind. The most challenging situation, I believe, is when you have a patient with severe psychiatric disorder, stabilized on a certain psychiatric regimen with great deal of difficulty and has remained stable over a long period of time, develops a medical illness where the range in psychiatric medication becomes necessary because either it is totally or relatively contraindicated given his medical condition. And you don't have the luxury of buying time to have a slow switch over to ensure that there are no complications while stopping one drug, starting another, and you are not even sure whether the other drug which you are going to start is going to be as effective as the original one, though it might be safer theoretically. On the other hand, we have got psychiatric patients who need medical treatment and need drugs like, say, steroids, which could have repercussions on the psychiatric aspects of the problem. So therefore, it's a complex situation, a difficult situation, challenging as well as rewarding. I think a close cooperation between physicians and psychiatrists are most important. It's something for all of us to learn all the time. Now we have not only new drugs, but even new diseases coming in like COVID-19. And it's very important that we update ourselves. Well, as an old man, I look upon this as an opportunity to update myself and look forward to further discussion. Thank you.
Dr. Satyanarayana sir, please introduce the speakers. Satyanarayana sir, please unmute yourself and introduce the speakers.
Now you are able to hear me?
Yes, sir. Yes.
Yes, we can hear you.
Okay. In the outset, I must be very happy and thankful to the Behavioural and Neuroscience Academy of India, especially Dr. Anukant Mittal for introducing me to this particular Banai. And thank you, Dr. Shahul Amin and Dr. Subhash Dikit and Debesh Ray for going to be the speakers, and the other chairperson, Dr. D.K. Deshmukh. The only request, Dr. Shahul Amin, I'm not able to, because I switched over to iPhone, and so I'm not able to see the slides of the speakers. So I want you to introduce the minute. I just want to speak for a few minutes, and then I will ask you to introduce the speakers because I'm not getting the screen properly. Okay? Fine, Shahul?
Okay, sir. Yeah, okay, sir. Okay, sir.
Yeah, before that, for a few minutes, I will talk. See, almost 40 years of my career, except 4 years is a stint as a director of mental health, 36 years, more than 36, I've been working in a general hospital setup. So always, right from day one, it's been always the reference is from neurology or urology or nephrology or cardiology or internal medicine or from obstetrics and gynecology. So there is a strong need for we psychiatrists to reintegrate into a general hospital psychiatry and licensed psychiatry. And especially the real problem comes in when you're on call. You enter the intensive care unit and you find the patient in a confused state. So you are not sure whether it is encephalopathy or hyponatremia or whether the patient is in an alcoholic withdrawal state. You are really confused and worried and all these things. But then the most complex thing is that what sort of a drugs to give. Whether shall I give SSRI or SNRI, whether this methacipine will be helpful or not, when the patient will become more confused because the renal parameter and pharmacokinetic, all these things will be really confusing. I think that is the reason why they have taken this topic as complex psychopharmacology of medically ill patients. It's really a big challenge and all these things, because they'll be already on other drugs. Drug interaction will be there. When the patient may be on a hyperthyroid and maybe a renal functions may be very low, he will have a hepatic failure. So all these things makes us really feel confused, and then we really have problems and all these things. So I think it's a wonderful topic. I'm sorry, my audio and video is not very clear and I'm not able to see the slides. So may I request now the moderator, Dr. Shahul Amin, to introduce Dr. Dikshit and Dr. Debashish Ray, please.
Okay, sir.
Thank
Our
you.
first speaker is Dr. Shubal Dikshit. He is currently the Director ICU at Sanjeevan Hospital. He did his MBBS from Bharati Vidyapith, Pune University, and MD Medicine from Pravara Rural Medical College and Hospital, Loni. He is the immediate past president of ISCCM, that is Indian Society of Critical Care Medicine, and also the immediate past chancellor of Indian College of Critical Care Medicine. Executive Council member, Academy of Pulmonary and Critical Care Medicine. And most importantly, he has received Presidential Citation Award at Agra in 2016 at the hands of National ISCCM President Dr. Shiva Iyer for his dedicated work in the field of critical care and outstanding contribution to ISCCM. Next slide, please. The second speaker is Dr. Debashish Ray. He is a senior consultant psychiatrist associated with MedStar Clinics, Apollo Glen Eagles Clinic, AMRI, Apollo Clinic and Hospital, Ruby General Hospital, Kolkata. He is a member of the International Research Committee of the International Society of Bipolar Disorders, ISBD, and a founder member of the Society of Bipolar Disorder, India. He has several national and international publications and presentations, and has chaired various scientific sessions in India and abroad. So with these words, I request Dr. Dikshit to start his presentation.
Yeah. At the outset, I would like to thank the organizing committee of Banani for inviting me to talk on this today's interesting topic. It was honestly a very interesting topic for me also to start off with for this. So I'll just start sharing my slide here. Yeah, they asked, I found it to be quite interesting and when I got the invitation to talk on such complex pharmacology in the medically ill patients. I'd never spoken about it. It was quite alarming things and the thought processes which were involved. I had a good discussion with Dr. Nagpal also regarding what I'm supposed to speak. So it was quite, as I evolved and as I started going through certain papers, it was quite interesting for me to go through with. And let's see how best I can do to cover it up. We know that the outline that the general all drugs, there is certain amount of pharmacokinetics and pharmacodynamics which is involved in medically ill patients and in critically ill patients. Of course, there is multiple organ failure. There is a hypoperfused state. These patients are in a shock state. And there are certain populations which are like liver failure, renal transplantations, or even OBGY patients who also come up. And these patients also sometimes post-traumatic stress disorders or post-head injury patients, they also require certain amount of medications. Or sometimes you also do see patients who consume a large amount of psychiatric drugs as a part of a suicidal attempt. So there is a lot of amount of changes which occur. They definitely hamper the physiology of the patient. They definitely hamper certain amount of outcomes into the patient. They also produce certain amount of problems into a patient, which I will definitely outline. The main objective is to consider about the different pharmacological treatments, discuss about the various pharmacokinetics and the various pharmacodynamics and what kind of medical problems and what kind of correlations which occur, and especially with drug interactions, especially which they occur into cardiovascular patients or those patients with liver failure, renal patient, or those patients who are into ventilated patients, and also those patients with stroke or a traumatic brain injury. The most general principle is, what is the evidence when you consider a drug to be given? The general consideration, we need to see the efficacy of the various specific agents, whether the drug is there used for psychiatric illness and whether it is associated with for a specific medical problem, or what is the evidence regarding the safety of these drugs into these specific situations where the patient is admitted with comorbid medical illness, and does psychiatric treatment really need to be adjusted depending upon the pharmacokinetics and the pharmacodynamics of the patient, and also whether the patient is in shock or whether the patient is in multiple organ failure. The studies are there, they're typically small or they're open. The patients are there with significant medical problems have been excluded and they're from the trials. The various psychodynamics which occur, what does the drug do to the body? Yes, of course, any drug which is there, these are all centrally acting, there is an impact on the brain. And because of the impact on the brain, especially in those patients with like stroke or a traumatic brain injury, of course, these patients could also produce certain amount of a decreased amount of level of consciousness. Or those patients who are in depression because being on the ventilator for a long period of time, when you use certain amount of antidepressants, they can also produce certain amount of depressive effect. And these patients can also remain on a ventilator and also have a situation of difficult to wean kind of situation. The peripheral impact also requires more amount of consideration, and often because of the basis of use of these psychotropic medications, especially for non-psychiatric indication like duloxetine, it is also used for as a pain management. An example, the SSRI or these serotonin receptors, they also act upon the gastrointestinal tract, and they also could produce a urinary kind of retention. And such kind of retentions can also present to the ICU with acute abdomen, or these patients can also have a stroke patients, especially who is antidepressant on a stroke. They can also have a retention and may need an unnecessary catheter, which can also increase the chances of secondary infections into ICUs. So what it does to the body, every drug, I need not tell all of you are doctors that of course there is a pharmacokinetics and pharmacodynamics. The absorption can be gastric or intestinal. Of course, there is a hepatic first pass effect which occurs, and this first pass effect may be hampered, especially if the patient is dealing with a gastrointestinal disorders, or in case if you have got a resection anastomosis which is being done, if the patient has got cytochrome P deficiencies which are present. The distribution may also be variable. If the patient is of a liver cirrhosis or a cardiac failure, there is a volume overload or pulmonary edema. If the protein binding is also a problem, especially in cases of nephropathy, then it's going to be a major problem. The hepatic, of course, the first pass metabolism where the cytochrome P5 oxidase enzyme deficiencies occurs, or at the same time, along with that, if there is a major organ dysfunction which occurs, then definitely is produced and precipitating of encephalopathy. Majority of the drugs mostly have got a renal excretion. So therefore, these patients, if the patient are in shock with renal dysfunction, these drugs are known to remain in the body for a longer period of time. They may produce certain amount of drowsiness or a difficult to wean situation. If the patient may also be remaining for a drowsy for a certain period of time, we may also start thinking whether it's a uremic encephalopathy or whether the patient has developed a fresh kind of stroke, or sometimes unnecessary investigation or a MRI oblique a CT may also be justified or may have to be required to be done, which can also add additional cost burden into the management of the patient. The harmful effects, what we have seen regarding the pharmacokinetics of these medical aids, yes, we have seen that intravenous medications or any rectal administration, they bypass the first pass effect. But most importantly, 100% bioavailability is there for intravenous administration, and the rectal absorption sometimes is erratic. And we have seen that majority of the drug interaction, they mainly occur because of the competition with the cytochrome P5 450 system. And this has been there from the pharmacological textbook, and impacting, it depends upon the volume distribution, and it also depends upon the protein binding, which is mainly responsible for, depending upon the patient is in shock or whether the patient is also into renal failure. The protein binding also can be variable. The pharmacokinetics, what is the rate? The rate again is influence again of absorption. If the patient has got resection anastomosis, of course there will be problem. If the decreased absorptive surface area may be there, and therefore rapid absorption may occur from a smaller surface area. If the patient has got a irritable bowel syndrome or ulcerative colitis with sepsis, of course these patients may be having motility problems, and there will be drug interactions which will be occurring with, along with rifaximin, which we also use into renal failure, or also as a selective decontamination of the gut. The bioavailability is the fraction which is administered where the dose remains unchanged, and this also may be variably reached depending upon the perfusion and also depending upon the shock state and what is the site of absorption, whether it is given intravenously or whether it is given orally. The absorption also may be variable. It also depends upon the pH, where the patient may be acidotic into intensive care unit. These patients may be shocked. There may be a decreased Planck or where a cerebral blood flow may be there. The lipid solubility is variable, and the protein binding, as I said, definitely is going to increase the drug effect if we find that more amount of protein binding is going to occur. And the most important thing is the unbound drug is the thing which is the most active form, and they produce the certain problems. And most of these psychotropic drugs are highly protein bound, except the lithium, the gabapentin, which you use for pain, or the venlafaxine, which is there. Now the metabolism, I told you, liver majority of the times is the first part effect. There is a gut wall. Absorption is quite good, especially in those patients where there is a mesenteric ischemia or a shock state, there is a paralytic ileus, and that can also precipitate a decreased amount of absorption. The hepatic metabolism may be altered in patients of acute viral hepatitis or patients of hepatic encephalopathy, and accordingly the clearance also may be variable. And depending upon that, the oxidation of the cytochrome P450 reduction or the hydrolysis. I won't go into the detailed biochemical metabolism or the biochemistry of it, but most importantly, you must remember that if there is absorption problem and if there is a hepatic or a renal problem, there is definitely going to be the metabolism problem by the first pass effect or the excretion problem, which is going to increase the drug levels, and they may produce certain amount of drowsiness, or they may, because of the drowsiness, it can also precipitate certain amount of complications or increased drug levels, which I will cover it in due course of time. The excretion by the kidneys, as I told you, is majority of the times. We need to sometimes adjust the dose as much as we adjust the dose of antibiotics into the intensive care units with the help of the calculating the create clearance with the Cockcroft equation. And remember, the half-life is more important. That is the amount of time which is excreted for the half of the drug to be excreted. Mind you, we do adjust depending upon the dose of antibiotics. We also plan the dialysis schedules depending upon the creatinine or depending upon the fluid levels or depending upon whether the patient is fluid clogged, whether the patient has got pulmonary edema, whether the patient has got liver cirrhosis, whether the patient has got accumulated fluid. We also need to calculate the cumulative fluid balance, which is important, and that cumulative fluid balance tells us how much amount of patient is fluid overloaded. In case if there is a large amount of fluid, the volume distribution or the dilution is also going to be very much higher side, and that can be another problems, especially if you're going to consider dialysis into these situations. As I told you that certain drugs are dependent on renal excretion. They are mainly the gabapentin and the lithium, and hemodialysis almost removes most of the hydrophilic but not the lipophilic kind of medications. We have seen sometimes lithium toxicity coming up into the intensive care unit, and most important into psychiatric medications, I need not go into the biochemistry of it, is the cytochrome P450 systems, and they exist mainly into the GIT, liver and the brain, and majority of the drugs, they are the inducers and they are the inhibitors into it. So the patterns of drug interactions which mainly occur into these critically ill patients are, there is an inhibition added to the substrate, or the substrate is being added to the inhibitor, and there is a removal of an inhibitor or there is a removal of an inducer. This takes you way back into our second year of a pharmacology talk which we hear. But you must remember that mainly in simple terms, it depends upon the volume distribution. It depends upon whether the patient is in liver failure and the renal failure. It depends upon the first pass biochemical effect, and it depends upon what is the rate of renal excretion and what are the renal functions. As I told you specifically now into liver diseases, which I will cover up, the absorption, if you see, these potential factors is in these patients, there is acidity. There is patients also, there is a motility problem. The enteric and the hepatic blood flow is also decreased. And because of liver cirrhosis, there is a portosystemic shunting, which is also occurring at 5 points in the body over the spleen, also into the rectal area. And because of this is important because they minimize the drugs with side effects, and the liquids are also better absorbed than solid. And you must consider the parenteral form in case if you need to be given. And because the distribution here, because of the hepatic blood flow, also because of albumin, which is going to go down because of liver cirrhosis, the binding affinities also go down. There are fluid shift. These patients are fluid clogged with ascites, and there is increased amount of volume distribution. The dose intervals also need to be changed. You need to reduce the doses or increase the intervals, because you must beware that the free levels are going to be on the higher side, and which are going to produce and precipitate a toxicity in liver failure. The metabolism, because of the first pass effect and the affection of the liver and the oxidation, there is a decreased hepatic blood flow, and the cirrhosis is mainly a severe issue, and majority of the times alcohol itself can also cause affection or a synergistic effect with these drug patterns which are there. In renal disease, again, we know that there is a affection of the protein glomerular basement membrane rate. The ammonia, the buffering which is there itself is acidosis, and they also increase the gastric pH. At the same time, uremia itself can also produce the small bowel amount of decreased absorption. But you must remember that significant clinical changes, especially for lithium or in gabapentin, and especially in renal failure, when you know that these patients have got pulmonary edema, or in patients of nephrotic syndrome where there's a large amount of volume overload, there is edema, there is dehydration, there is also going to be a salt wasting, loss of albumin levels. Therefore, monitoring of these levels is very important. And mind you, not all institutes or not all hospitals are well equipped to monitor the drug levels. Or sometimes the drug levels are not easily available, and therefore you have to use it depending upon the creatinine clearance using the Cockcroft equation, and that is much more easier and much more cumbersome as much as we adjust the doses as far as antibiotics is also concerned. Now let's take a case-wise distribution here. Like a 55-year-old male who has come with a CAD, he has got a myocardial infarction, who is admitted with a physician. A myocardial infarction is ruled out. He gets a severe panic attacks since his return to work, as well as mild depressive symptoms. He's extremely busy professional with no time for psychotherapy, but would like to take medications for his symptom because he's a typical page 3 high so executive. Now, if these patients are because of the panic attack, in case if you treat these patients, of course, the antidepressant or the anxiolytic medications can also hamper, and they can also alter with and interfere with the cardiovascular disease. How? Sertraline, it sounds good and safe into medical patients because of this, as per the enriched trials and the sad heart trials which were published way back in JAMA 2002. Now the mirtazapine, which was used, the MINDED trial, it had no side effects which were there. Of course, it precipitated sedation. Citalopram, per the CREATE trial, which was also published way back in JAMA and was quite reported and safe. But mind you, citalopram up to 40 milligrams, if the dose goes on increasing, it also produces an increase in the QTC, and it also produces a torsa or a ventricular arrhythmias. Or escitalopram, which we use, it is the DECART trial, is again considered to be safe, and this was published into a pharmacological journal in 2012. Now these SSRIs, they also have got side effects. They precipitate hypertension, they may produce tachyarrhythmias, sometimes they can also impair the platelet aggregation, and especially if these patients have got a post-plasty patients, there also may be a significant amount of drug interactions which will occur with aspirin or clopidogrel. Now citalopram, there is a QTC prolongation which can occur, which can precipitate a torsion, or the venlafaxine can also increase hypertension. The tricyclic antidepressants, yes, it may precipitate antiarrhythmias or sometimes ventricular fibrillation following a QTC prolongation, which is there, or certain drugs may produce orthostatic hypotension. Other effects which we have seen, yes, we have seen the risperidone, hypertension and hypotension both. There is mainly a fluctuations of the orthostatic hypotension which may be precipitated by olanzapine or the QTPin, which is there. Although the clozapine also, mainly it's a tachyarrhythmias, prolonged QTC syndromes, sudden deaths can also be precipitated into these kind of patients, and especially in certain patients who have got a dilated cardiomyopathy or a dilated heart. Definitely this is situations you really need to see and monitor it. Of course, you must have an electrocardiogram which is done prior, and if these patients is above the age of 50 with hypertension, diabetes and ischemic heart disease, I would definitely recommend a proper cardiac evaluation or at least a 2D echocardiogram to be done to see the ejection fraction into these patients. Antipsychotic drugs, as I told you, they increase the QTC interval, although it is seen that there is limited amount of data with low risk has been seen with certain amount of drugs, but most helpful is important is you have to see that you do not prolong the QTC. Of course, as much as you monitor the sugar levels, of course, you need to see on these patients on a follow-up basis whether there is an increase in the QTC, or you need to discuss it with the psychiatrist whether he wants to stop it in case if there's a prolongation of QTC, which can also precipitate certain amount of life-threatening torsade, which can be life-threatening into these situations. Now, cardiovascular, not only these, torsade is also induced by psychotropic drugs, and not only because of this, certain drugs may also precipitate hypokalemia. There is also high doses can be seen, and there is a heart disease, and mainly prevalence into a female kind of gender is almost about 70% prevalence, which is seen here. So it's very simple. You need to evaluate the heart, take a ECG, do a echo, see that the sugar levels are also normal, and also have a follow-up ECG which is being done on a follow-up into the intensive care unit or onto the hospital when these patients have been started. Certain blocks have been reported with certain anti-epileptic also, which we use, like the valproic acid, which is also used even in patients for a migraine prophylaxis, or Tegretol or carbamazepine, which we use. They can also be precipitate a eosinophilic kind of myocarditis because they're known to increase certain amount of eosinophil count. And lamotrigine can also precipitate a chest pain. Now, a second patient is alcohol dependent. There is history of delirium. He's a 40-year-old. He's admitted with tremens, admitted to the ICU with liver failure following Tylenol ingestion in a suicidal attempt. She is confused with ammonia of 180, but is also tremulous, diaphoretic. There are fluctuating blood pressures, and the team does not want to give sedatives because they can alter the mental status. So what sort of things you like to control it? At the same time, there is a suicidal attempt. The patient is also confused. There is a liver failure. The ammonia is also increased. means the patient is also restless, has got tremors, has got sweating, and there's a fluctuations of the blood pressure. Now, these patients, the hepatotoxicity risk also needs to be considered. If you are going to use a divalproex, the elevated amount of triaminases, SGOT, SGPT, can be seen in about 1 to 5% of these patients. Liver failure has been seen, and even ammonia, mind you, can also go up with certain amount of because of the drug itself. Mind you, especially if these patients are also onto a branch chain amino acid infusion, if these patients also post pancreatitis or liver failure following a surgery, these patients also require certain amount of nutrition that can also increase the ammonia. And in case if they are going to combine it with certain amount of drugs like this, they may also precipitate certain amount of increase, and you don't know whether it's related to the drug or whether it's purely related to the infection or the sepsis. Similarly, disulfiram or duloxetine, which you are using, yes, they precipitate elevated enzymes and transaminases, so you need to monitor it. And this was also seen, and you need to monitor the SGOT and the SGPT quite frequently into these patients. While in my unit, definitely if these patients is there, we definitely monitor it every 5 days, at least the SGOT, SGPT, to cut down the cost rather than doing a full liver function test. You also need to see your ECG, which are into these patients for monitoring of the cardiac arrhythmias. And not only because of cardiac arrhythmias is this, it in ICU, it also be because of electrolyte imbalance. And this era of medical legal situation, definitely monitoring is equally important. Monitoring of the drug also plays a very important role, as much as delivery of the drug system is also there. Common antipsychotic have also been elevated, I told you, in about 2 to 5-10% of these patients. Ketipin or oleanzopine, it is quite rare with Respidone, and no reports have been seen with the asapins which have been there into these drugs. And of course, with the availability of new drugs, definitely the side effects are going to be less. The age-old benzodiazepines, whether it's alprazolam or whether it's a lorazepam or any form, of course, we use the infusion also into the ICUs, but they typically worsen encephalopathy. They can also worsen respiratory failure. They can also produce a large amount of a delayed. Patients don't wake up for 2 days or 3 days in case of an infusion is given. So in case of a sedation protocol, we definitely see an early morning interruption of the drugs therapy to see whether the patient wakes up. We just want to see that the patient is sedated in such a level or controlled in such a level that on tapping of the shoulder, he opens his eyes and definitely corresponds and follows certain amount of orders. Otherwise, the patient with renal failure or hepatic dysfunction, they remain on the ventilator for a long period of time. The length of stay increases, the morbidity increases, secondary cost also increases, secondary infections increases, difficult to wean situations from mechanical ventilation also occurs. And sometimes if the patient doesn't wake up, we have a neurologist coming in and he say that, especially he's at age about 65, he'll say, just rule out whether you have not developed a stroke because of a hyperperfuse or a shock kind of state. And as I said, sometimes a scan also can be done. Not only this, they also precipitate and have got certain problems. If the patient continues to be on longer period of time or drowsy, if the patient is not get weaned off, certain patients may also land up onto a tracheostomy. They have to undergo a tracheostomy, either percute or surgical, which increases the surgical load or the procedure burden onto the intensive care unit, further adding to the cost. Now the dialysis patients who's there, he's a renal failure patient with duloxetine. The team is asking for evaluation for depression, and the patient displays a flat effect. And when you assess the patient, you also make a diagnosis for hypoactive kind of delirium and what sort of recommendations should be done. And as I said, majority of the indications of dose adjustments need to be done depending upon the creatinine clearance as per the Cochrane, as much as we adjust the antibiotic schedules. Renal insufficiency also plays, and there is a concomitant hepatorenal failure or cardiac failure, multiple organ failure. So therefore, excretion also will be variable depending upon the dose adjustments and the needs what are there. In dialysis patients, small studies have been done. There are pharmacokinetics and psychological drug effects which are there. There have also been the mirtazapine or the amitriptyline levels which are decreased significantly after dialysis. And there are states where fluoxetine, which is there, after 8 weeks of treatment were comparable in both the groups, and increased concentration forms of tricyclic antidepressants were found in dialysis patients, while the elimination of the half-life was longer in dialysis patients than in the control patients. Lithium, yes, it's used for as an antipsychotic. A single dose after each amount of a dialysis treatment. It requires frequent lithium monitoring. I need not tell you, you're the experts into lithium. And GFR, mind you, in this failure is not a good indication for lithium dose adjustment vis-a-vis if you compare it with other and form of antidepressants or antipsychotic. So the dose adjustments are required, especially in renal failure, are as per the venlafaxine or the duloxetine, which we normally use. Antipsychotics is mainly the risperidone, which is the mood stabilizers, which we use is lithium, pregabalin or the gabapentin, and other drugs, lorazepam or even the bupropion, which we consider that you require recommended dose adjustments into such kind of situations. Now, these renals also, they contribute to other effects. Not only this, lithium can precipitate diabetes insipidus, they can also produce a reversible amount of a kidney toxicity. We have got urinary incontinence and retention which can occur. There is also a diabetes SIADH like syndrome where the osmolarity gets hampered. There also tropinate can also precipitate renal stones. But mind you, most important is the urinary retention, the amount of polyuria or diabetes insipidus and SIADH, which sometimes require frequent monitoring, and they also produce a large amount of electrolyte imbalance. In respiratory failure, those who are intubated, ventilated, or those patients who are on non-invasive ventilator, certain patients, the CO2 levels may go up. These patients may require intubation. These patients, yes, you can use a small sedation effect into it. You can use a small antidepressant, but mind you, again, it also needs to be adjusted depending whether the patient has got hypoxemia, whether the patient has got antipsychotics, what kind of sedation. There is a sedation score where we use it, because giving more amount of sedation is also going to produce certain amount of respiratory depression, and this respiratory depression can also produce a laryngeal dystonia, which can also increase the risk of aspiration with more amount of antipsychotics, which we sometimes continue. Tegretol, if taken for a long time, can also produce certain amount of parenchymal or amount of damage, which can also hamper the ventilation perfusion ratio, a difficult to wean situation, these kind of problems which may also occur. And the safety exists, especially with antidepressants, citalopram. They have shown that these kind of patients, which you use sertraline or citalopram for depression in COPD patients into small studies, as a small amount of stimulant we found modafinil, which is there, or the zolpidem, which we use, or melatonin also for regulation of the sleep patterns, what we also use into these patients sometimes are beneficial into certain kind of studies. But mind you, they require very close amount of monitoring. Those patients who are obese, those patients who have got obstructive sleep apnea or obesity, hypoventilation syndrome, they itself are depressed because they can't lose weight. These patients, because of depression, can be on to certain medications. These patients may also be on this, and they can also precipitate and cause a laryngeal dystonia. They can also increase the chances of these aspiration, and similarly, sometimes asthma can also be precipitated. There is increased mortality, especially if you discontinue it because of the anticholinergic rebound which can occur into certain subset of patients. We get stroke patients. Of course, stroke patients may also get depressed because certain patients' recovery is not guaranteed. We don't know how much amount of patients will recover from stroke, but certain patients may have depression into these post-stroke kind of depressive episodes, and you require certain amount of counseling. And along with counseling, of course, mood stabilizers are given. They are good neuroprotectors, but mind you, you need to use it because certain amount of depression can also produce decreased level of consciousness, and decreased level of consciousness may hamper the GCS score into the intensive care unit, and that kind certain patients may also continue to be, if the GCS falls below 6, then definitely it becomes an indication for intubation. So sometimes if you don't stop it or don't analyze it, if you don't adjust the doses, then it may also precipitate and land up into other complications into this. Pseudobulbar problems which can occur with sertraline or citalopram, and though it has been documented, definitely aspiration is one problem because the pseudobulbar affectivity which occurs. Itself, we know that Parkinson's itself can also precipitate depression. There is also that if you progress from a stage 1 Parkinson's to a stage 4 Parkinson's, where used duloxetine, SSRI, tricyclic antidepressants, they are more effective than SSRI, they are less tolerated. But into these kind of situations, there is a good amount of drug interactions which also occur. They may produce certain amount of depression, urinary retention which can also occur. The motility can also be a problem into it. So therefore, optimization of the anti-Parkinson's therapy along with the anticholinergic inhibitors, it may be helpful if psychosis and cognitively impaired patients are there. Again, if you're using antipsychotic, you need to have clobazam, which should be used with close and adequate amount of monitoring, or the quetiapine. Of course, there is limited data, but these patients also have got motor side effects and certain drugs which are available. I'm not a psychiatrist, so please spare me for certain pronunciations of these drugs, but certain these produce and hamper it. And in patients where traumatic brain injury which come up, these patients into rehabilitation, where these patients are trauma, there are cerebral contusions, there may be a large amount of a subdural or a chronic subdural producing hygromas, where definitely certain amount of cortical atrophy can occur. These patients can also be depressed, there could be confusion loss, and you don't know whether the confusion loss is purely because of the brain or purely because of the antipsychotic medications what the patient is being taken on. So in conclusion, definitely in the medical setting, you may be asked to prescribe it because the patient has got problems such as obesity, renal failure, the patient is often depressed, the patient is on a ventilator for a long period of time, the patient is spending repeated admissions because of liver dysfunction, there is a lack of appetite. So we should know that what is the efficacy of the drug, when and how to adjust the doses, and most important, we need to say a polite no due to the negative effect in case if it's going to do more harm than good. Thank you very much for the patient hearing.
Thanks, sir, for a very comprehensive presentation, especially with the case examples that sounded less theoretical and more practical, practice-oriented. And I was told that Dr. Dixit will be leaving us. He will not be waiting for the discussion section
Yeah,
because
I
he has
have another talk at 8:45. I need to join.
So, on behalf of everybody in the audience side, I thank you, sir, for a very comprehensive, very elaborate, very useful presentation.
Thank you very
Thanks,
much.
sir.
Thank you very much. And stay safe. Thank you.
Now I invite Dr. Debashish Ray for his presentation. Sir, please. Over to you.
Hi, good evening. Let me start sharing my screen. One sec. Is it visible?
Yes, sir. Yes, sir.
Right. So what brings us here is basically, as we know, as clinicians, we come across patients with a lot of these medical morbidities. And then we are faced with a lot of dilemmas, like the medical comorbidity actually can worsen the psychiatric illness. Medicines which are used for the medical illness can actually worsen the psychiatric illness. And similarly, psychiatric medications can also worsen the coexisting medical illness. Again, we have these medical comorbidity which can actually influence the pharmacokinetics of the medicine. For example, if there's an end-stage liver disease, the drug elimination of the psychotropics are slowed down. Then we have an interaction, a drug interaction between the psychotropic drug and the so-called non-psychotropic drug. For example, a person who's being treated for depression and migraine, we can get a serotonin syndrome when SSRIs are used in conjunction with any triptan. And then we have these underlying genetic vulnerabilities, like poor metabolizers, the Caucasians who are poor metabolizers of cytochrome P450. And similarly, histocompatibility gene, which is associated with a higher susceptibility to toxic epidermal necrolysis or Stevens-Johnson syndrome with carbamazepine. And there are problems galore. Interestingly, what we find is that we are not the guys who prescribe the most of the psychotropics. The GPs prescribe the most of the psychotropics, and we prescribe even less than half of the psychotropic drugs that's prescribed across the world. So I'm just going to be very brief about talking about some of the nuances of the individual disorders, because most of them have been covered by the earlier speaker, Dr. Dixit. Psychopharmacology of medically ill children and adolescents, and psychopharmacology of the new medical entity that is COVID-19. When we concern the gastroenterological disorders, we have primarily these four. If we can specify this on the basis of organs, oropharyngeal disorders include burning mouth syndrome, which is basically seen in perimenopausal and postmenopausal women. And the treatment here is dispersible, clonazepam primarily in a dose of say around 1 milligram per day. Others are also, like sertraline, amisulpride, and paroxetine may also be helpful. Xerostomia, dryness of mouth, which is a very common symptom, both with psychotropic drugs, primarily those with the anticholinergic activities, and also with other medical conditions which can coexist in tandem. Here we can use pilocarpine 1%, which can be made from the eye drops with aqueous solution of pilocarpine, and topical fluoride can also be used. Dysphagia sometimes may be the only symptom of extrapyramidal syndrome. And dysphagia sometimes presents in the psychomedical situation as a very challenging condition. It may also be a manifestation of neuroleptic malignant syndrome, and also a presentation of tardive dyskinesia. If the dysphagia is acute, it becomes sometimes life-threatening. IV benztropine or diphenhydramine is the treatment of choice. In case of tardive dyskinesia, in case of tardive dysphagia, clonazepam has been found to be very helpful. Globus hystericus, it has got a lot of these psychiatric connotations. People used to believe that globus hystericus is primarily psychogenic, classically associated with depression, anxiety, conversion issues. But there are also, organic substrates of this globus hystericus. For example, gastroesophageal reflux disease, lingual tonsil hypertrophy, and tricyclic antidepressants are the mainstay over here. Primarily tricyclics like nortriptyline and trimipramine. Gastroesophageal reflux disease is one of the commonest gastrointestinal disorders that that anyone can come across in general practice. We have to avoid anticholinergics over here. We have to avoid tertiary tricyclics like imipramine, amitriptyline, clomipramine. The treatment is basically diazepam, 5 milligrams to 10 milligrams twice daily. Other non-tertiary amine tricyclics like nortriptyline and desipramine, and sometimes even SNRIs like duloxetine. The non-cardiac chest pain is also being very commonly presented. Here also tricyclics play a major role, along with benzodiazepines and buspirone. Concerning non-ulcer dyspepsia, low-dose trazodone starting from about 12.5 milligrams, and tricyclics like nortriptyline are very helpful. SSRIs have to be avoided. Peptic ulcer disease, doxepin and trimipramine have been useful, probably because they're antihistaminic and anticholinergic actions. When after a gastric bypass, what happens is, the drugs which are usually in aqueous solution, they are absorbed faster. And as you know, most of the psychotropics are lipophilic. So it creates a dilemma with us concerning, which formulation to use and which molecule to use. It's always better to convert any extended release preparation to an immediate release preparation. and to use orally disintegrative tablets. Also, after bariatric surgery, the classical notion is to hike up the dose of many drugs, because the pharmacokinetics of most of the psychotropic molecules except bupropion and lithium becomes completely unpredictable after bariatric surgery. Inflammatory bowel disease is something which is being very commonly associated with depression. There's about 3 times more depression in the inflammatory bowel disease than in the control population. And even this depression happens to be the strongest predictor of the response of Crohn's disease to infliximab. So the presence of depression in Crohn's disease indicates a poor response to infliximab. The treatment here is with paroxetine. Bupropion and phenenzyl may also help. Bupropion possibly by inhibiting the tumor necrosis factor alpha, and phenelzin by reducing the gut motility. Irritable bowel syndrome, we all know, it is the commonest neuropsychiatric gastrointestinal presentation that we come across in our office practice, associated with not only depression, anxiety, and the somatoform spectrum, but also rarely with ADHD and substance use disorders. The treatment here with diarrhea predominant IBS, tricyclics, and myosin, which is not available in India. With constipation predominant, it's primarily the SSRIs. Paroxetine possibly helps in both the diarrhea predominant and the constipation predominant IBSs. The hepatic metabolism part has been covered by Dr. Dixit to a great extent. What happens over here is, what is important is concerning the end-stage renal disease and the reduced synthesis of plasma proteins in a damaged liver, which causes an influx of free drug levels. So the drug blood levels have to be monitored. The blood levels of the psychotropic drugs have to be monitored wherever it's available, whenever it's feasible. And it's always pertinent to monitor the free drug levels. Always avoid medicines which have a very short therapeutic window. For example, lithium. Avoid drugs, which have a longer half-life, like fluoxetine. Avoid drugs, try to avoid these extended release preparations. You have to be cautious with drugs which are hydrophilic because of the increase in volume, like lithium oxazepam and valproate. And most importantly, adjust the dose of the psychotropic drug according to the Child-Pugh score. Now, what is this Child-Pugh score? It's basically an item-based rating pattern employing 5 parameters, that is total bilirubin, serum albumin, prothrombin time, ascites, and hepatic encephalopathy to quantify the severity of liver damage on one hand, to prognostify the liver damage on the other, and possibly to translate this quantification and the prognosis to treatment recommendations. So what happens, it is advised that with 5 to 6 points, we have to probably modify the dose, reduce the regular psychotropic dose to around 75%. Or you can even remain, you can keep it unchanged. 5 to 6 points is not threatening. With an increase, say around when the point increases to 7 to 9%, half the dose. If it increases further, you have to be very cautious. And sometimes it's better to either withdraw the molecule, withdraw the psychotropic, or keep on monitoring blood levels. If not possible, you have to have a regular and very, very frequent clinical monitoring. This chart is also quite helpful, in when we are dealing with a psychiatric patient with comorbid hepatopathy. These are the molecules which are not, either they are not metabolized or they're minimally metabolized by the liver. We have desvenlafaxine, pregabalin, lorazepam, as we all know, antipsychotics like paliperidone, amisulpride, mood stabilizers, lithium, lamotrigine, and also molecules which we use in dementia and in other conditions, memantine. When we are discussing about renal disorders, this end-stage renal disease, is almost a cousin of depressive disorder. When they're present together, it is very difficult to tease them out. And teasing them out is extremely important to treat the comorbid depression with ESRD. Because all these symptoms, as you see, fatigue, dysomnia, pruritus, anorexia, and constipation are common to both. In fact, the prevalence of depression is very high in end-stage renal disease. Then we have also cognitive dysfunction in renal disease. Sometimes in the height of uremia, delirium, when the creatinine also rises very high, we have hallucinations. The patient hallucinates. So any renal disease can sometimes mimic a psychiatric disorder and sometimes a major psychiatric disorder. Similarly, we have psychogenic polydipsia, which can probably, fox you as a renal disease. One of the ways in distinguishing this from diabetes insipidus will be to restrict the water intake and then, measure the osmolality. We should not be very much bothered about the renal metabolism and the renal pathology when psychotropics are administered, except for medicines like lithium, gabapentin, pregabalin, topiramate, which causes renal stones, along with zonisamide, paliperidone, risperidone, paroxetine, desvenlafaxine, venlafaxine, and memantine, because these are the molecules which undergo renal metabolism, specifically lithium, which has been touted as renotoxic. Hemodialysis and peritoneal dialysis definitely does have a telling effect on renal clearance, and these drugs, we have to be very careful about that. Chronic renal disease can sometimes modify both the first pass and the second pass hepatic metabolism and affecting the cytochrome P450. So what happens to the hemodialysis patient? We have to be very cautious with duloxetine. We have to be mindful about the dose of mirtazapine and amitriptyline. Probably we'll have to increase the dose. Fluoxetine dose is not affected, along with its metabolite norfluoxetine. But mind you, fluoxetine has a very, very long half-life. Lithium, again, the dose has to be given after the hemodialysis has been over. Be very careful after the entire course. And the dialysable drugs are gabapentin, lithium, pregabalin, topiramate, and valproate. Dialysable drugs for peritoneal dialysis includes lithium. Concerning cardiovascular disorders, all of us know the SAD heart trial and the ENRICH trial concerning sertraline, quite ancient. Nortriptyline, interestingly, has been found to work well with patients with, left ventricular dysfunction, left ventricular hypertrophy. TCAs, definitely, they have quinidine-like properties. They cause orthostatic hypotension, need to be avoided. There's some limited data concerning the role of paroxetine in congestive cardiac failure. It has not been firmly established, though. All the other medicines like TCAs, trazodone, and mirtazapine, they may increase weight, and some mirtazapine particularly an initiator of the metabolic syndrome, which may not be good for people who are vulnerable to uh, cardiovascular disease. Bupropion may be used for weight loss. Other disorders which we have been, there are plenty and plethora of disorders which we come across. Respiratory disorders, there's a branch called psycho-oncology, psychodermatology. We have other disorders like, luteal phase dysphoric disorder, issues in pregnancy, etc. I'm just going to briefly touch on some of them. In congestive cardio, in COPD, it's better to avoid the classical antidepressants. Tetracyclics are what is preferred. Benzos should not be used or should be very sparingly used because they cause respiratory depression. So in any patient, whether it is a short-acting benzo or a long-acting benzo or an intermediate-acting benzo, we have to be very careful when you are using this in in a bronchial asthma or in any respiratory disorder. Beta blockers, on the other hand, beta blockers are not contraindicated. Specifically, the selective beta blockers are not contraindicated. They have to be used with caution. They may sometimes aggravate bronchial asthma. They may sometimes interact with some bronchodilators, but they are not usually absolutely contraindicated. What is interesting will be the neuropsychiatric complications of interferon and interleukin. Both of them have got severe and serious neuropsychiatric complications. Skin disorders, we have a very, very high prevalence of suicidal ideation in skin disorders, especially in psoriasis and other skin disorders which are, some sort of treatment recalcitrant. Important drug interactions over here will be the CYP3A4 inhibitors with CYP3A substrates like pymoside, which is sometimes used in syndromes like delusional parasitosis. So doxepin is something which has been very useful. It takes care of both the itching and the sleep disturbance. Organ transplantation issues have already been discussed. Now, fluoxetine has been the antidepressant of choice in children. It's been the only approved SSRI. But look at its long half-life, and it's also a potent inhibitor of CYP2D6. So a child with any other medical comorbidity, with any other taking any other non-psychotropic drug, we have to use fluoxetine with caution. Better, sertraline is probably much better. Citalopram and escitalopram can also be used, but again, recently, citalopram and escitalopram both have this QTC prolongation issue. So much so that FDA has restricted the use of citalopram to not more than 20 milligrams per day in liver damage when cimetidine or ranitidine has been used, and in again the genetic vulnerability, poor CYP219 metabolizers. When we should use SSRIs in children, sometimes there's this antibiotic called linezolid. When used with SSRIs, it may cause serotonin syndrome. So what do we have to do with this? When linezolid has been used in a child or an adolescent, we should not use it within 2 weeks. There has to be a 2-week washout period, before we start an SSRI. The platelets should be at least 1 lakh before we start an SSRI in a post-linezolid patient. It's better sometimes to use nortriptyline in 6 years or more, or amitriptyline or desipramine in 12 years or more. There has also been this talk about, the association of SSRIs and suicide, primarily from the British literature. Some people have rubbished it completely. We try to identify and find out some of the risk factors which can cause, be of interest in case of SSRI associated suicide, which contains family history of suicide disorder, comorbid psychiatric disorder, pain, poor social support, poor coping skills, and the time stage of depression when the depressive symptoms are resolving partially, or there's a surge of impulsivity. Iatrogenic medical trauma, which is almost following on the lines of PTSD, is very common in children. What happens here? The first line treatment is again citalopram. The others are risperidone low dose, very low dose, quetiapine, propranolol, and clonidine can also be used. Delirium in children and adolescents is something which we will discuss later afterwards. Now, benzodiazepines. What about benzodiazepines and anxiety, PTSD, etc. in children? Sometimes what has happened is, like they use in the geriatric populations, benzodiazepines here cause a paradoxical agitation, increase the anxiety paradoxically. And so they are not recommended in PTSD in children, in any sort of an anxiety disorder in children and adolescents. The commonest delirium that we find in children and adolescents is the hypoactive delirium, as contrasted to the adults. Here, risperidone low dose, 2 to 4 milligrams per day is advised. Hyperactive delirium responds well to haloperidol, whereas sometimes melatonin, probably by reducing tryptophan and probably in its role in serotonin breakdown, may be considered as an adjunct. We come to the final part of my presentation, that is psychopharmacology of COVID-19. There have been a lot of discussion about the psychiatry of the pandemics, and COVID-19 per se has been associated with an increased prevalence of psychiatric disorders, both independent of COVID-19 and in association of COVID-19. One of the antipsychotics that we have to be very, very careful in prescribing in a COVID-19 patient is clozapine. Again, because of mobility restrictions and other logistic issues, monitoring of neutrophil count becomes difficult. So instead of the reduction in the frequency of monitoring, clinical features of agranulocytosis have to be looked into carefully. Clozapine also increases the risk of pneumonia. This has to be clinically assessed because pneumonia induced by COVID-19 can be aggravated by clozapine, and this may actually, worsen the entire outcome of the disorder. Leukopenia and lymphopenia is found in both COVID-19 and clozapine. What to do about that? We may not have to discontinue clozapine if the absolute neutrophil count is normal. Even if the TLC is less, even if the total leukocyte is less, if the neutrophil count is normal, we can keep on continuing clozapine. If there's an acute infection, if there's a high fever, which actually increases the levels of clozapine and actually augments the toxicity, consider halving the dose of clozapine. And if there are evidence of toxicity, primarily, measured through the blood assay, etc., discontinue. If there are clinical symptoms, please discontinue because of even cardiovascular risk factors. Other antipsychotics are primarily involved concerning the QTc interval and liver function diseases. Concerning the mood stabilizers, carbamazepine also causes leukemia, leukopenia, and lymphopenia. It also causes aplastic anemia. There's also, in conjunction with the acute liver injury of the COVID-19, we have to monitor the complete blood count. If there is, if there's a fall, if there's a reticulocytosis or a aplastic anemia, change it. Change the mood stabilizer. And try to avoid carbamazepine in case of liver injury. Valproic acid in COVID-19 is primarily, meddling with the coagulopathies. There's an increase in the prothrombin time. There's an increase in the alpha PTT and reduction in the platelet, both in COVID patients. And there's also a thrombocytopenia with valproic acid, which is not dose dependent. So we have to monitor the platelet count. And if there's thrombocytopenia, we have to avoid valproic acid. Gabapentin, again, with its, hassle with the renal injury, have to be avoided in case, because of the fact that there is a very high chance of renal pathology or subsequent renal injury in COVID-19. SSRIs and SNRIs, we probably have to monitor concerning the coagulopathies because both of them cause impaired platelet aggregation and may sometimes cause abnormal bleeding. So bupropion may be preferred if there's no issue of seizures or if there's no indication that the seizure threshold is going to be lowered. COVID also increase, acute liver injury, duloxetine will have to be avoided. QTc prolongation is something which is again to be considered, especially with regard to citalopram and escitalopram. The other medicines, lithium, we have to adjust lithium. We may not have to discontinue lithium, but if there's renal pathology, it's better to withdraw lithium or, wait till the renal pathology normalizes. Benzos, there are these agents like lopinavir and ritonavir, which are used frequently in COVID-19, which are contraindicated with midazolam and triazolam. What happens with the medicines? What are the psychotropic effects of the medicines which are used in COVID-19, and how do they interact with the psychotropics that we use? Azithromycin prolongs QTc. Chloroquine, hydroxychloroquine, metabolized by CYP3A4. So they may interact with fluoxetine. They may interact with carbamazepine, oxcarbazepine, and modafinil. It has a very long half-life. So with any other CYP3A4 inhibitors, there's a high chance of other adverse effects. Colchicine may give rise to a lot of other disorders like delirium, delirium and seizures. It has a very narrow therapeutic index. Again, it has to be used very cautiously with fluoxetine. Interferon, there's a boxed warning with interferon concerning serious and fatal neuropsychiatric disorders. Look at the extent of depression that's been caused by interferon. Suicidality, anxiety disorders, and it also has a potential for bone marrow suppression. So use cautiously with carbamazepine, valproate, and clozapine. Lopinavir and ritonavir, we have already discussed that, contraindicated with midazolam and temazepam. It's mobilized quite substantially by CYP450. The concentration may get increased with other CYP3A4 or CYP2D6 inducers. The concentration may reduce with CYP1A2 or CYP2B6 substrates. It lowers the concentration of bupropion, methadone, lamotrigine, and olanzapine. Vitamin C, which is very commonly used, it hardly has any psychiatric side effects, but when used in conjunction with barbiturates, which is also rarely used these days, barbiturates may actually reduce the effects of vitamin C. So concluding, when we are faced with a person with psychiatric disorder and medical comorbidity, we have to be very clear about the diagnosis. Concern, for example, a case of depression with end-stage renal disease, whether this depression is syndromal or is only a consequence of the end-stage renal disease. The treatment differs. We have to correctly identify the target symptoms for which we are going to use the psychotropic agent. It cannot be just a blanket prescription that, okay, just because this person has hallucinations, we are going to use olanzapine and induce a metabolic syndrome. We have to carefully consider drug interactions, not only among psychotropic and non-psychotropic drugs, but also among other psychotropic drugs in this era of psychiatric polypharmacy, not only concerning the CYP40, but also concerning the paraglycoproteins. We have to be misers. We have to have pharmacological parsimony. We have to think thrice or four times before before a psychotropic drug leaps out of your pen. So like in geriatric psychopharmacology, we start low and go slow in psychopharmacology with medically ill patients, but do not stop until a complete trial, and do not stop until you are sensing an adverse effect or an adverse effect appears. Thank you very much.
Thanks, Dr. Ray, for a very comprehensive presentation. There was a lot of new information, especially about the psychopharmacology of COVID-19 management in some of the patients who have comorbid medical disorders. Very comprehensive, very useful presentation. So now we will start taking up some of the questions from the audience. We have quite a few of them. I will start with a question from Dr. Bharati Challa. So what she is asking is, like most of the antipsychotics do have cardiac adverse effects, agreed, but especially in elderly people, we may have to use them, especially if the patients have insomnia, restlessness and all, even if they have, suppose, ECG abnormalities, echo abnormalities and all. So how to go about in such people, elderly people who have cardiac abnormalities, if they have insomnia and restlessness, managing with antipsychotics or other agents?
Do we have to manage the insomnia and restlessness with antipsychotics only?
There is a question. So
one of the antipsychotics of choice would be definitely aripiprazole, which will again give rise to akathisia. And I would probably, sometimes a very low dose of clozapine, in spite of the fact that clozapine, would give rise to an tachycardia. In the elderly, clozapine would probably be the best bet. Quetiapine, olanzapine definitely have a much more serious load of weight gain and metabolic syndrome. Sometimes both of them will induce Parkinsonism-like syndromes. So clozapine, there have been anecdotal studies about clozapine in some elderly individuals, even giving rise to weight loss. And in a dose like 12.5 to 25 or even less than 25, used sparingly, it may not lead to any cardiological side effects. If you're needing a sedative antipsychotic. The other one would be definitely thioridazine, which is not very popular now, but thioridazine is fraught with the side effects of orthostatic hypotension, some anticholinergic effects which may, cognitively impair the elderly, but thioridazine may also have to be considered.
Okay, thank you. Another question from Dr. Sripati Santosh. He is asking about the role of amantadine in patients after post like head injury. They have a coma, stupor, disorders of consciousness. Any role of amantadine?
Amantadine definitely has a role there, but amantadine is not fraught with neuropsychiatric side effects. In fact, amantadine sometimes does give rise to depression. In the long term, there are some reports of amantadine giving rise to cognitive decline. Some patients also have a delusional feature which is reversible in Parkinsonism when amantadine has been employed. Primarily in the elderly, there has been a reversible delusional syndrome which has been described in amantadine. But if it's used for a very, for a specified period, amantadine can be used.
Okay, thank you. Now there are two related questions. I will club them. It is basically about the attitude of doctors from other specialties and all. One question is from Dr. B. Ramesh Babu. He is sharing an experience where he had a patient who had a chronic renal failure and depression. And on antidepressant, the patient developed somnolence, sedation. So the nephrologist team asked to reduce the dose, and eventually the patient committed suicide. So how to like motivate or maybe increase the faith of the other specialists in psychotropics and in psychiatric treatment. Likewise, Dr. Ashok Kumar Khaitan has also asked a similar question, like the stigma the other specialists have about psychiatry, the psychiatric treatments and all. So how to handle that? Social stigma, apathy, especially GPs have towards mental illness. So how to handle these kind of attitude issues?
What we all have in hand are not the GPs in the in the immediate context of a practice. We don't have the GPs, we have the patients. So we'll have to start with the patients, and primarily educate them about the illness and the medicine and how the medicine is going to act. So we are also going to probably preemptively educate them about the negative feedbacks they are going to receive from other people, including non-psychiatric professionals. So that would probably sort of immunize or opsonize our patients against changing the dose of the psychotropics or even withdrawing the psychotropics by themselves without proper psychiatric advice. This is the first part where we can start. The second part is definitely a non-psychiatric outreach program where we can, educate them or converse with them. But in practicality, it is sometimes very difficult with, in practice, you cannot probably universalize this approach.
Okay. Okay, thank you. So the next question, actually, you told about the antibiotic linezolid causing serotonin syndrome. So there is a question from Sanjeev Saoji that what if one has to start linezolid in a patient who is already on SSRI?
Sorry, yeah. On SSRI, and would you please repeat the question?
No, the patient is already on SSRI. So
Yes.
if one has to start linezolid in such a patient, so the risk of serotonin syndrome and also how to go about that?
You do not start because there will be, you do not start because, and it depends again on the half-life of SSRI when you have to start linezolid. You have to go for other because serotonin syndrome in children would be quite disastrous to manage.
Okay, thank you. Another question again from Dr. Bharati Challa. She's asking about hyponatremia leads to delirium. So how best to manage the insomnia part, especially whether there is any role for melatonin in such patients? Hyponatremia and delirium.
Yeah. Yes, because we can definitely use a lot of agents which do not give rise to syndrome of inappropriate ADHD secretions to induce sleep across the populations. And melatonin can definitely be used. Melatonin can sometimes be used as a primary agent. in a higher dose, and it can also be used as an adjunct when we are using agents like trazodone, when we are using non-Z drugs to treat hyponatremia without incurring the risk of hyponatremia.
Okay, thank you. Another question from Dr. Shripati Santosh. It is about managing COVID. One is how to manage steroid psychosis in COVID patients. Steroid psychosis. The other second part is there any precaution that need to be taken in patients who recently recovered from COVID-19, psychopharmacology wise?
Any precaution that's needed to
be taken when you are prescribing psychotropics to any patient who recently recovered from COVID-19?
Okay. The first one, the steroid psychosis, again, it depends on where the patient is, whether the patient is, inpatient or outpatient. We have to, if the patient is an inpatient, we'll have to probably exclude whether the patient is in the intensive care, whether the patient is actually suffering from intensive care psychosis, or whether this is a conglomeration of both intensive care psychosis and steroid psychosis. If it is an outpatient, we'll have to find out whether this patient has a pharmacological history, a psychotropic pharmacological history in the family of good response to any antipsychotics, if there's a history of any psychosis in the family. And concerning the patient's metabolic profile, we have to choose the, antipsychotic, definitely an atypical antipsychotic, olanzapine, risperidone. If it is a severe thing, sometimes even loxapine may be of good help. If the patient has other issues like swallowing, etc. So it again depends on a myriad of situations, and we'll have to select the antipsychotic.
Okay, thank you. Another question again from Dr. Sanjeev Saoji. Can lithium be given or continued in a patient who has hypothyroidism?
Yes, definitely. There are a lot of patients in which we do give lithium, because lithium will be the only mood stabilizer which will work in that patient. Either this patient comes to you with a hypothyroidism before a drug naive, a psychotropic drug naive patient with hypothyroidism comes to you, and this patient's clinical profile is very strongly predictive of a very good lithium response. Why not go for lithium? One. Second, you have a patient on lithium who develops lithium-induced hypothyroidism, but probably lithium is the best mood stabilizer in that patient, or lithium is lithium is something which is indispensable pharmacologically for the patient. So it's not desirable to withdraw lithium. You have to carefully monitor hypothyroidism, go for a thyroid diet, go for thyroid supplementation as and when required. And this is what I would like to do.
Okay, thank you. One question from Dr. Ravi Soni. It is about elderly patients who already have hyponatremia or history of hyponatremia. They are on other medications, etc. So how to manage depression in such patients?
Yeah, it's a very good question. Most of the SSRIs possibly cause hyponatremia, and a lot of other. So what we have to do is, hyponatremia, sometimes we can use molecules like nortriptyline. There is also a very low incidence of hyponatremia, which has been reported so far with vortioxetine. Now, in spite of giving so-called sodium-saving antidepressants, we sometimes come across hyponatremia in the elderly patients. So it's always better to monitor that, create a protocol for sodium supplementation. One of the mistakes that we do, if there's a hyponatremia with the sodium level of 130 or more, we start supplementing sodium. This actually worsens the hyponatremia. What we'll have to probably do is to restrict the water intake of the individual. And if it's 130 or less, we can probably supplement sodium, monitoring other issues.
Okay, thank you. So I think we are already crossed the allotted time. So I will hand it over back to the chairpersons. They have to also announce the person who asked the best question. Back to you, sirs. Deshmukh sir and Satyanarayana sir.
Maybe I think Dr. Deshmukh sir, I mean, I think he's a very senior person, and then...
No, I think it should be your choice primarily.
No, I think that one of the questions was about hyponatremia, because as I was mentioning earlier, this is a challenging thing that we always come across. Because, see, as a psychiatrist, you have been called, and then you just go there, and then usually it is not just a depression, no, right? So you don't find the depression, but the depression occurring in an individual who is already having some physical illness. Apart from that, we have to think in terms of the pharmacokinetics, drug-drug interactions, and the bioavailability of the drug, whether it is a hepatic metabolized drug or what will affect the kidneys and all these things, and especially this ammonia, buffering, all these things. No, this is what baffles a psychiatrist. It is not simply you say, okay, you take escitalopram or mirtazapine or something like that. So I tried that particular question, and then really challenging is about hyponatremia. Whoever has asked the last question, I think it's one of the good questions that has been. That question, because it generally baffles us every time, and it's a really challenging thing and all these things.
Yes.
But of course, see, most of the other things like QTC prolongation, cardiac arrhythmias, or hypokalemia, these are all the general things that we always we come across and all these things, because we always look in terms of a renal profile or whether it's a hepatotoxic and all these things. So I was one of the feel that one of the questions about hypernatremia is, Sir Deshmukh sir, that you please tell me, I mean, looked into the other questions, and what do you feel?
No, I think I was also thinking along the same lines.
Okay, so
So what do you, moderator? What do you think, moderator? Because you are the one who has been going through the questions and all.
No, I am the person supposed to announce, sir. It is the...
No, Debashri, where, I mean, if some questions had baffled Dr. Debashri, then probably I thought I would give questions. But then he was so cold, like like an examiner, and with a smiling face was answering all these things. As a moderator, what do you feel? Is there any other question that possibly...
No. I agree with the decision. Fully agree with the decision that the two of you took, sir. So that price, that Amazon e-voucher of Rs 5,000 goes to Dr. Ravi Soni. You asked that question on that hyponatremia, how to manage a patient who has hyponatremia and has depression. Congrats to Dr. Ravi Soni for that.
Congratulations, Dr. Ravi Soni. Yeah.
Congratulations.
Yeah. Yeah, especially, I mean, as he was mentioning, elderly with multiple comorbidities, it's really a baffling thing. And that's why probably the people thought the topic itself is complex psychopharmacology in medically ill patients.
Okay, sir, over to the organizers then. Back to them.
Yeah. Thank you. Thank you,
everyone.
Mitchell. Thank you, Shaul Amin.
Thanks, everyone.
This is Deveshri and Dr.
Thanks,
Deshmukh.
everyone.
Thank you,
all.
everyone.
Thank you so much.
Thank you all for joining us today. We hope to see you again on coming Tuesday. Please block your date for 2nd March 2021, same time from 8 p.m. to 9:30 p.m. Topic for our next webinar is Microscopy to Neuroimaging, Multi-Scale Neuroscience of Psychiatric Disorders. Also, based on many requests that we have received, we would like to inform you that all our previous webinar archives are now available on our YouTube channel, Banai India. Do send us your feedback and comments, if any, on info@banai.org.in. Till then, stay safe. Good night.
Good night. Thank you. Thank you.
Thank you. Good night.